Ever wondered how enzymes power every move your muscles make? Curious about how specific enzymes fuel your muscles and reveal signs of health or damage? Let's find out. Today, we'll uncover the secrets of two vital muscle enzymes, creatine kinase, CK, and aldolase. Discover their crucial roles in muscle function, their clinical significance, and how they can help diagnose muscle-related conditions. Hello everyone. I'm Mohammed Hamama, and welcome to your ASCP preparation camp. Before we dive in, make sure to subscribe to our channel and activate notifications for more insights into medical laboratory science. Give this video a thumbs up if you find it helpful. It helps us reach more aspiring medical laboratory scientists. Let's get started. Creatine kinase, the powerhouse enzyme. Function of creatine kinase. CK is essential for muscle energy management, catalyzing the phosphorylation of creatine by ATP. During muscle contraction, CK rephosphorylates ADP to ATP using creatine phosphate, CRP, ensuring a continuous supply of energy. Optimal conditions. The enzyme functions optimally at pH 9.0 for the forward reaction and pH 6.7 for the reverse. Magnesium ions are crucial for activation, but in high concentrations, they inhibit CK activity. Various ions and inhibitors also affect its functionality. Tissue distribution. CK activity is highest in striated muscle and heart tissues, with lower activity levels in the brain, smooth muscle, liver, and erythrocytes. CK is a dimer composed of subunits from chromosomes 14 and 19. Isoenzymes. CK exists in several isoenzymes. CK1, BB, CK2, MB, and CK3, MM found in the cytosol or myofibrils. CKMT, a mitochondrial isoenzyme making up 15% of heart CK activity. Macromolecular CK, types 1 and 2 larger forms with varying clinical significance. Macro-CK types. Macro-CK type 1, a complex of CK, usually CKBB, and an immunoglobulin, often IgG. It can cause elevated CK levels but isn't pathologically significant. Macro-CK type 2, oligomeric CKMT, more common in severely ill adults and associated with a poor prognosis. CK isoforms. CKMM2 and CKMM1 differ in the removal of lysine residues. CKMB2 and CKMB1 vary based on their gene coding and post-translational modifications. Muscle damage indicator. CK levels rise in cases of muscle injury, inflammation, or necrosis. Elevated CK can indicate conditions like muscular dystrophy, viral myositis, and inflammatory myopathies, but not neurogenic muscle diseases. Other causes of elevated CK. Trauma, certain medications like statins, and conditions such as malignant hyperthermia can also elevate CK levels. Monitoring recommendations. Routine CK monitoring isn't recommended for asymptomatic patients. However, in patients with muscle pain and weakness, CK assessment can guide treatment decisions. Assay methods. Various methods, including photometric and fluorometric, are used to determine CK activity. Modern assays favor the reverse reaction due to its faster rate. Aldolase, a glycolytic enzyme. Function. Aldolase plays a crucial role in glycolysis by splitting D-fructose 1,6-diphosphate into D-glyceraldehyde 3-phosphate, GLAP, and dihydroxyacetone phosphate, DAP. Structure and isoenzymes. Aldolase is a tetramer with subunits from 3 separate gene loci. The most common isoenzyme pattern consists of various proportions of components from a 5-member set. Serum isoenzyme. The primary isoenzyme in normal serum is the A homomer, predominantly found in skeletal muscle. Clinical significance. Serum aldolase levels are of interest in diagnosing primary skeletal muscle diseases like progressive muscular dystrophy and polymyositis. However, its diagnostic value is limited compared to CK. Measurement methods. Assay methods are based on the forward aldolase catalyzed reaction, coupling with other enzyme reactions to measure NADH concentration. Sample handling and reference intervals. Serum aldolase activity is stable for up to 48 hours at ambient temperatures. Hemolyzed specimens should be avoided. Reference intervals vary, with higher levels observed in men, newborns, and children. Next, we have liver enzymes. Have you ever wondered what enzymes can tell us about the health of our liver? What roles do aminotransferases play in liver function? How can they help diagnose liver diseases? Liver enzymes include alanine aminotransferase, ALT, aspartate aminotransferase, AST, glutamate dehydrogenase, GLDH, alkaline phosphatase, ALP, 5-nucleotidase, and gamma-glutamyl-transferase, GGT. Today, we'll explore two crucial liver enzymes, aspartate aminotransferase, AST, and alanine aminotransferase, ALT. We'll dive into their functions, clinical significance, and how they are used in diagnosing liver conditions. Be sure to stay tuned for our next video, where we'll cover the remaining liver enzymes. If you've made it this far, be sure to like and subscribe if you haven't already. Also, check out our store for your next date outfit. Your support helps us continue creating valuable content. Let's get started. What are aminotransferases? Aminotransferases are enzymes that facilitate the conversion of amino acids to 2-oxo acids by transferring amino groups. The two clinically relevant examples are aspartate aminotransferase, AST, also known as L-aspartate 2-oxyglutarate aminotransferase. Alanine aminotransferase, ALT, also known as L-alanine 2-oxyglutarate aminotransferase. Reaction specifics and coenzymes. Reaction specifics. The 2-oxyglutarate/L-glutamate pair acts as the amino group acceptor and donor in all aminotransfer reactions. AST favors the formation of aspartate, while ALT favors alanine production. These reactions are reversible. Coenzymes and regeneration. Pyridoxal 5-phosphate, P5P acts as a coenzyme, binding to the inactive apoenzyme, and transferring the amino group to 2-oxyglutarate, forming glutamate. P5P is regenerated in the process. Distribution in the body. AST. Found primarily in the heart, liver, skeletal muscle, and kidney. Exists in both mitochondrial and cytoplasmic forms. ALT. Primarily found in the liver and kidney. Lesser amounts in the heart and skeletal muscle. Exclusively cytoplasmic. Liver disease and transaminase activity. Liver disease is the primary cause of increased transaminase activity in serum. Both AST and ALT levels rise when liver cell integrity is compromised, with ALT being more liver-specific. ALT versus AST. ALT rarely increases in conditions other than parenchymal liver disease and persists longer than AST. AST, determined alongside ALT for specific conditions like alcoholic hepatitis, hepatic cirrhosis, and liver neoplasia. Diagnostic thresholds. An efficient threshold for diagnosing acute liver injury is ALT greater than 7 times the upper reference limit, URL, with sensitivity and specificity greater than 95%. Prognosis and chronic hepatitis. Peak transaminase activities don't correlate with prognosis. Persistent increased ALT for over 6 months after acute hepatitis indicates chronic hepatitis. Specific conditions and other causes. Toxic hepatitis versus infectious hepatitis. Acetaminophen-induced hepatic injury shows transaminase peaks greater than 85 times the URL, with AST and ALT peaking early and declining rapidly. NAFLD and aminotransferases. NAFLD ranges from simple fat accumulation to severe non-alcoholic steatohepatitis, NASH, associated with metabolic syndrome features. Cirrhosis. In cirrhosis, ALT production decreases in a damaged liver, while AST clearance reduces in advancing fibrosis. An AST to ALT ratio greater than 1 suggests advanced fibrosis. Liver carcinoma and medications. Both AST and ALT increase in liver carcinoma, with AST usually higher. Medications can cause slight to moderate increases in aminotransferases. Measurement and assay system. Measurement process. Measures transaminase activity indirectly by focusing on the formation or consumption of oxoacids, coupling reactions with specific dehydrogenase reactions. NADH monitoring. NADH is oxidized to NAD+ during the reactions, with absorbance at 340 nanometers measured to reflect substrate transformation. Standardization and reference procedures. Standardizing transaminase measurements is crucial for patient care. IFCC reference procedures ensure universal comparability. Reference intervals and stability. AST reference interval. For adults, the URL is 35 unit per liter, 97.5 th percentile, with no significant sex-related differences. Serum AST activity in children under 3 years is twice that in adults. ALT reference interval. Men, 60 unit per liter, women, 42 unit per liter. ALT does not show distinct age dependency during childhood. Storage and stability. AST activity remains stable in serum for up to 48 hours at 4 degrees Celsius. ALT should be assayed on the same day due to temperature sensitivity. If you found this video informative, please like, share, and subscribe. Any questions or comments? Leave them below. Be sure to grab your free copy of the ASCP short notes, check the description for the link. You can also support us by purchasing products from our store, this helps us continue creating valuable content. Stay tuned for our next video.